Hey everybody, sorry for being a little late today. That's okay. This my first lecture is not going to take the whole hour, so it actually kind of works perfectly here. Again, I'm Dr. Taylor Payne, one of the EMS fellows to UAB. We're going to talk about pain management today. So this is a brief overview of what we're going to talk about. We're just going to go to over an intro real quick, talk about some pathophysiology, what actually the human body does to create the perception of pain. What's your initial evaluation? Are there any tools you use? Kind of what you're thinking about when you evaluate somebody that's complaining of pain. We'll talk about a few different pain scales and how or how not they may be useful in certain scenarios. Talk specifically about opioid analgesics because that's going to be your lion's share of what you treat patients with in the pre-hospital setting. We'll briefly talk about some non-opioid analgesics, especially since Toradol and Tylenol is going to be hopefully coming to the state protocol over the next few months. We'll talk about those drugs and what to look out for. And then just the general dosage for some of these medications and some general precautions of what to look out for. All right, so introduction, right? So 80% of all chief complaints, now this is ER, but 80% of all chief complaints are related to pain, all right? Chest pain, leg pain, trauma, whatever. So the big thing we're trying to do, right? We're trying to eliminate pain. We're trying to eliminate suffering to the best of our ability, right? There's some patients that are more susceptible to oligoamnesia, which is inadequate pain management, right? So the old, young, those that might be confused, right? So we got to think about that when we're picking certain drugs and we're picking certain dosages. We want to make sure we can adequately manage somebody's suffering to the best of our ability. Anytime we talk about pain management, there's concern for prescription pain misuse, right? We see that all the time, and that's something we think about when we're picking our drugs and what we want to use, right? So should we give this person narcotics if we think, they're abusing the system or they're just trying to be pain-seeking in some way? So those are all things to think about and things to evaluate, right? So in thinking about that specifically, the bottom line is pain medicine in an acute setting should not be withheld if there is a concern for addiction, unless the specific circumstances is known and somebody that has clear evidence that they might be drug seeking, right? Otherwise, you should always err on the side of caution and treat somebody aggressively with pain control. Again, every patient is different, so I'm going to talk about some generalized concepts, but again, it's going to depend on the patient that's in front of you, right? What we're going to do, how we're going to treat them, how much we're going to give them. It all is very specific to the patient in front of you. So pain management as a whole, there's two different approaches, right? There's the mechanistic approach and the symptomatic approach. The mechanistic is the ideal way, right? You're actually determining what's causing the pain, and you're actually working on a mechanism that will hopefully eliminate the pain, right? So this would be like sumatriptans for migraines, right? You're actually looking at the serotonin receptors and working on those that are thought to be the actual cause of the pain, right? And then there's the symptomatic approach. And all we're doing here is really trying to mask the pain symptoms, but we're not directly affecting the cause of what's causing their pain. So that's what we do with opiates, right? Opioids. That's our mainstay, right? So you got to remember, we're not actually treating or curing the pain. We're just treating the symptoms of the pain. So we got to talk a little bit about pathophys. Don't let this slide scare you, right? So this is just at the bottom of the picture here. We got the tissue, local tissue, right? So local tissue will see some kind of damage or injury or noxious stimuli is what you'll hear people say. They'll release certain chemical mediators right there in that local tissue, and then the nerves will pick up on that and send the nerves all the way to the CNS, right? It goes to the dorsal root ganglion, which is just the posterior side of the spinal cord, and you can see on the right side how it just tracks up and it'll go all the way up to the CNS. Right, so there's a lot of different moving parts here, right? So it's not just a switch on and off that causes pain, right? So you have multiple different areas where different things can come in and manipulate the perception of pain. Right, so you might have a certain signal come up, but the brain might perceive it a certain way based off previous experiences. So it's got to process that input, and then it's going to create a perception of pain, right? And that's why it's so difficult sometimes to treat pain, because everybody's different. Everybody has a different perception of pain. again, we talked about the central nervous system, right? So that's the big computer taking all the inputs in and creating a conscious perception of pain. And again, it's really not a one-way switch that's, hey, this pain is on and off. It's really a process of all the different inputs coming together to create this identity, this perception. You'll hear people talk about somatic versus visceral pain, right? So somatic is just your everyday pain. This is traumatic, you know, if you break your ankle, if you have a laceration on your leg, right? So you have specific receptors in those regions, nociceptors. Those are specific pain receptors, and that kind of acts like the pathway that I just described, where you have the nerves that run up the spinal cord into the CNS. The other type of pain is visceral. It's more complicated. So that involves most of the hollow organs. You can think about most of the organs in the abdominal cavity. And the difference between visceral and somatic is somatic will give you a specific location that the pain is originating from, right? Where visceral is really going to give you a generalized area, but you're not going to be able to pinpoint the location. So this is why people with abdominal pain really can't tell you exactly where the pain is, right? Because it's a totally different pain pathway. So they might say, yeah, I'm in pain. It's just kind of all over. They can't, you know, point to one certain area. Now, over time, say appendicitis, sometimes it will localize to a certain area as it switches over to more the somatic pathways. But in general, your visceral is going to be your abdominal cavity, and it's going to be very poorly localized. And then you can also get this concept of referred pain, right? So this determines where the pain inputs are coming into the spinal cord. You can think of it like as the spinal cord gets confused at the inputs. And so it will tell your brain that, hey, this pain is actually coming from a different location than it actually is. So that's why sometimes you'll get referred pain to the shoulder. Somebody would be complaining about shoulder pain, and it'll really be a diaphragm injury or some type of abdominal injury that irritates the diaphragm, causing that referred pain to the shoulder. So the individual will actually sense the pain in their shoulder, but the pain is actually originating from their abdominal cavity. Okay, specifically talking about opioid analgesics, right? So most of these will bind to these receptors in the spinal cord in the brain. There's three main types. There's one other one, but there's three main types. There's the mu, which most people have heard of. There's mu1, mu2, kappa, and delta. Okay, mu is going to be the most important for pain control. These receptors, besides being found in the brain and your spinal cord and peripheral nervous system, are also found in the GI tract. So this is why we see a lot of the side effects of constipation from these medications, because you have those same receptors in the abdominal tract, GI tract. So each opioid that we give is going to react to these receptors in different ways and different degrees. But most of them in the way they have a mechanism on pain is they're going to stimulate the mu1 and the mu2 receptors, okay? So you can see here, mu1 will produce supraspinal analgesia, so that's really working on the receptors in your CNS. And then the mu2 are going to be more peripheral, and this creates more of your side effects or adverse effects, right? So you get your euphoria, your meiosis, respiratory depression, and depressed GI motility. That's all coming from this mu2 receptor that is working on. The delta receptor is, you know, one of the other three I talked about. It'll produce mild analgesia, not to the effect of the mu receptor. And it also has an antidepressant effect too, which helps it become addicting as well. So the kappa is the one that gives more of the delirium, dysphoria, disassociation, kind of the weird feeling, I guess. It's not the high or euphoria. That's more with the mu. So this kind of gives all the other side effects that you'll see people complain about when you push morphine. So let's briefly talk about evaluation of pain, right? So there's a lot of different scales you can look up. There's different numeric scales. There's, I think I actually have a slide here. Just some of the general scales you can use. You know, there's been a lot of studies on these. Mainly, these are most helpful in the research setting, right? Because you're trying to assign a specific number to see if there's a change based off the medication. In the pre-hospital setting, emergency care setting, I think it's less useful. It still can be useful, right? Most people just use the numeric system 1 to 10, 10 being the worst pain you've ever felt. And sometimes you have to remind people, you know, that 10 would be the worst pain you've ever felt, right? But these are some different scales you can use. Again, I would probably recommend for severity, just using a 1 to 10. I think that's easiest. And again, it keeps everybody on the same page. Again, not just severity though, right? For pain, you're trying to determine location, and all this is trying to figure out, you know, what's the underlying cause of the pain. So you're trying to figure out location, duration, how long it's been going on. Quality, so that's like what type of pain is it, right? Is it burning? Is it stabbing? Is it sharp? That can kind of point you a certain way about what's going on. And then any alleviating or worsening, exacerbating factors. A lot of people will base their pain assessment on physiologic criteria. So like, oh, well, their heart rate's normal, so they must not actually be in that much pain. They've actually done studies on this, and there is a weak correlation. It's not a great correlation. So most people will say that treat the patient, unless you just have a huge concern for misuse of pain medication, treat the patients based off their subjective pain scale assessment, right? Don't just go off of physiologic measures, heart rate, blood pressure, things like that. All right, so now we're going to move on to treatment. So you've evaluated, you've come on scene, you've kind of come up with a small differential diagnosis in your head. You're thinking about what it could be, and then you're going to work on trying to pick the most appropriate pain medicine, right? So in the past protocol, it was easy, right? You really only had opiates. That was kind of the only pain management tools we had, right? Well, now with the new protocols that should be rolling out sometime this spring, they're going to be adding on Toradol and Tylenol, right? So it's important to think about these things. It's important to think about when to use them and what to look out for. Okay. So NSAIDs, so your non-steroidal anti-inflammatory drugs, right? So that's your over-the-counter ibuprofen. Tylenol is kind of a little different category. It works similar, but it doesn't have as much anti-inflammatory effects as ibuprofen and Toradol. So that's really not considered an NSAID as much. These are great for mild to moderate pain. And even in specific circumstances, severe pain, these respond very well to, okay? So one of the classic examples is Toradol for kidney stones, okay? So if you have a suspected kidney stone, it's a young patient, doesn't have any other comorbidities, this could be a first-line drug, even if they're in 8 out of 10 severe pain, okay? This is great for this. And why it works so well in kidney stones is actually the mechanism of the peristalsis of the ureter around the kidney stone is basically constricting against that stone, and that's what caused the colicky intermittent pain. Well, the Toradol actually takes out that mechanism. So this is kind of a more mechanistic approach, and that's why it helps with this pain so much. So that's something to think about. And then opiates, right? Cornerstone of management for moderate to severe pain. Again, we've talked about often affected by concerns for adverse events, right? So you have to take that into account when you're thinking about dosages, and especially monitoring these patients after you give pain management is very important. So what's some considerations, right? Desired onset of action, your available routes, other pain agents on board that the patient's already taken prior that you've gotten there, or if they're chronically on opioids, maybe they already have a little dependence on it, and you might have to have a little higher dose for those patients. And then, of course, side effects, right? You're wanting to minimize side effects. You want to pick out those specific patient populations that might be more susceptible to having respiratory depression. I know this is a lot on this slide. If you know, you probably want to take a picture of this or whatever and go back and look at it later. But this is a great list of different opiates and their time of onset, you know, peak effect, how long they last. Of course, really the only ones we use in the pre-hospital setting on this page: fentanyl, morphine. A lot of these other ones are oral that we don't give in the pre-hospital setting. We give a lot in the ER. But you can see here at the top, right, morphine. So the usual dose, 0.1 milligram per kilogram, or 2 to 4 milligrams, I believe is what the state protocol says for morphine. You can see pretty quick onset IV, right? So 1 to 2 minutes IV, and it'll last, you know, 1 to 2 hours, right? So that should be appropriate for most transports, at least unless you're doing an inter-facility hospital transport. And then you have fentanyl at the bottom, right? Quicker onset actually than morphine. it won't last as long. And you can see the normal dose there, 1 mic per kg. Usually 50 to 100 is your dose for fentanyl. And we'll talk about certain patients where you may want to change that dose. We'll also look at the very end of the new state protocols in regards to pain management and kind of what they suggest as well. So you can kind of all wrap this up and put it together at the end. So this is just a zoomed in picture of the fentanyl and morphine at the top. You can see the comments. I think we'll talk about this. But so morphine is kind of famous for its histamine release. It's just one of the mechanism of action it has. More than the other opioids is that it causes a pretty large histamine release. So histamine, just like if you had an allergic reaction, is going to cause hives, itching. It can cause vasodilation. So that's what gives you the hypotension is the histamine release. I think we talk about that here and again in a little while. So opiates, right? So you want to titrate to effect, right? So the safest approach is to give the dose that you think is most appropriate up front. Don't give the max dose up front, and then titrate as needed, right? So this is the safest way to do it. Again, it's going to be related to their age, their initial pain severity, what actually you think is going on, and that's going to determine what initial dosage you're going to get. True, a lot of people say they have opioid reaction, like, I'm allergic to morphine and whatever, and that's actually really rare to have a true allergy to opioids. Most of the time, what people are describing is that histamine release. So they'll say, yeah, I got a little itching, and it's really not actually hypersensitivity. It's more of a side effect, right? So it's not an allergic reaction. Fentanyl is actually less rare as well. Some people will describe allergic reactions as, I felt funny, or, my head started spinning, I got dizzy, and they'll say they're allergic to it. So just something to consider when patients say that. So, and speaking of adverse effects, of course, we've all seen nausea and vomiting, very common with opioids. Constipation is a side effect more long-term. Pruritus or itching, urinary retention you can see, confusion, mostly in the elderly when we give it, and then respiratory depression, of course, is the one we know good and well. So let's talk about Tylenol, right? So non-opioid agents that we can use to try to spare are opioid drugs, right? So these are going to be great for mild to moderate pain. Most everybody, I think, presenting with mild to moderate pain should get this, and they would have an indication for this. A couple things you got to think about, but overall, it's a pretty safe drug, right? So the biggest thing you want to assess is if they've had it already. Like, did they take it before you got there, right? Because you're going to want to know that before you give it to them. It doesn't affect platelet aggregation, right? So things like aspirin and other NSAIDs that we kind of worry about. Tylenol doesn't affect that as much. So that's why it's usually thought as a little safer than NSAIDs. The only bad thing is Tylenol doesn't have the anti-inflammatory properties as other NSAIDs like ibuprofen or Toradol has, so you won't get as much pain relief necessarily. But again, it's a little safer drug. And there's no real dosing change required for renal or mild hepatic impairment. Yes, you're not going to want to give as much in a end-stage cirrhotic patient that has a good bit of liver dysfunction. You can still give it, but you're not going to want to give as much. But for renal patients, there's no dosage change requirements. So this is another page that shows non-opioid analgesics, kind of their first recommended dose. Again, you're going to go off the state protocol for first dose on these, but this just kind of gives you a generalized overview and things to look out for each one, right? So we can see at the top, Tylenol, 325 to 1,000 milligrams every 4 to 6 hours. Some places actually give it IV, not as much in the US, that's more in Europe. The max dose, if you think about it, if you look on the little label, it's about 3.9 or 4 grams a day. So you can think of 1,000 milligram doses a day is your max for a healthy patient. So even if a patient took a gram earlier in the day and it's later on the day, you can go ahead and give them another gram. It's not gonna find, as long as it's within 4 to 6 hours or outside of 4 to 6 hours of the previous dose. And then here is your Toradol near the bottom, Ketorolac. That's your generic for Toradol. I believe the state protocol is going to be 15 milligrams IV or IM. So that's going to be your initial dose. It lasts very long. The mechanism or the length is, 4 to 6 hours. I think it says on here somewhere. The thing you got to think about with Toradol is the side effects, right? And the different precautions that you're going to want to take. So acetaminophen, we already talked about. Max dose per day is 4 grams. Initial dose for mild to moderate pain, 650 milligrams or 1,000 milligrams. I usually just go up front and give them 1 gram. And again, as we start using these new protocols and you start giving this more and more and more in the field, it's really important that you hand off this information to the emergency departments when you come in, because often this is given as a already set order in the ER, before a physician even has to see them or put in orders. The nurse will automatically kind of click this as an order, and they can go ahead and give them a gram. So it's important that you tell the staff, hey, I already gave them a gram of Tylenol, so we don't give them another gram back to back. The Toradol, right? The big drug everybody's kind of talked about recently. So this is a great opioid sparing agent. Again, it's an NSAID, just like ibuprofen. It has anti-inflammatory and analgesic effects. The mechanism of action is it decreases the production of prostaglandins and this arachidonic acid. You don't really have to worry about that. It's basically the chemical mediators at the site of tissue injury that tells the nerves, hey, you need to send a pain signal to the brain. It actually decreases the production of those at the tissue level. So that's why it decreases the inflammatory markers and the different inflammatory activity around the specific tissue site. And then, of course, the analgesic effects is this COX-2 enzyme inhibitor. That's the same way aspirin and other NSAIDs work. What's cool about this is it actually, by this mechanism, inhibits hyperalgesia. So a lot of people will have pain out of proportion to injury just because of the local chemical reactors, and this will help with that greatly. Okay. Of course, this is not going to cause any respiratory depression, and it's not going to interfere with any bladder or bowel function, so we don't have to worry about those adverse events. And it has a, while we're trying to push this and use it more, is it has a good opioid sparing effect. So some of these patients you don't have to give opiates after, and even those that you do have to kind of rescue with the opioid drug, you don't have to use it as much or for as long. In that. So these are the big things we're worried about with Toradol, right? So this is really the thing you got to think about before you give Toradol. It can cause some platelet dysfunction. The big things are GI irritation and nephropathy. Okay, this really can hurt the kidneys fairly well. So it's important to think about it. It's important to not use in any patients that have a history of kidney dysfunction, or if you're just on a patient and you suspect they might have acute renal injury. Right, if you come up with somebody and they haven't eaten in 2 or 3 days and you think they're really dehydrated, there's a good likelihood that that patient has a kidney injury, and you're not going to want to give Toradol to that patient. This is more common in the elderly. I think I'll talk about it. So most places won't recommend giving Toradol over say a 60-year-old patient, okay, just because that increase of kidney damage and injury goes up exponentially as your age goes up. All right, and then we got to talk about ketamine, right? So ketamine, everybody knows it's a anesthetic, it's an analgesic at lower doses. It's actually a derivative of PCP. That's kind of why you get into nystagmus with it, just like you do with PCP. It's an NMDA agonist. That's how it causes its dissociation. Of course, the advantage is in the appropriate dosages, it will cause minimal respiratory depression over slow IV push. Right? If you give it really quick, you can cause somebody to be apneic in a short period of time. But overall, ketamine is safe if you give it at the appropriate doses for the appropriate indications. And it should cause minimal respiratory depression, if any. Again, typical dosage for ketamine, 0.15 to 0.3. A lot of places say over 10 minutes. I know nobody's really giving that over 10 minutes in the field, but try to be a slow IV push if you can. If you can do it over a minute or so, that'd be great. And then the side effects, right? So this is really why we try to steer away from ketamine when we're talking about pain control. I know some agencies use ketamine only for pain control, and I think that's actually going to be changed in the state over the next couple of years. You're going to be required to carry either morphine or fentanyl. You can't just carry ketamine. you get hypersalivation, you have this reemergent reaction, delirium, people call it, being in the K-hole or whatever. Of course, you can have hallucinations and emesis. The reemergent reaction and delirium, that's more at the anesthetic doses, your 1 milligram per kilogram or higher dosages. You shouldn't get that as much with your pain doses, but I'm sure if you've given this in the field for pain, you can see a lot of people will complain about this feeling of unreality. They might start hallucinating even at these low doses, okay? So it's really not a good first line for pain, in my opinion. Also, it's really not good for chest pain, right? So ketamine will increase your sympathetic tone. It'll cause tachycardia, your blood pressure to go up. And of course, if somebody's having a heart attack, right, we're not going to want to increase their cardiac demand. We're not going to want to increase their cardiac ischemia, right? So this really should never be used in chest pain. So again, we've talked about this a lot, but safe and effective use of opioids is facilitated by appropriate initial dose and then subsequently titrating additional doses based on the patient's reaction to it and the initial insult, whatever their initial traumatic event is. This will avoid over-medication and minimize all your adverse events. It's also important to note in opioid-naive patients, right, you're going to want to monitor them very closely, right? You can be surprised that even at an appropriate dose, they might have pretty decent ultramental status and some respiratory depression. So this might be a patient you want to just put on end-tidal CO2 and really closely monitor them on the way to the hospital. Again, hypotension is infrequent. It does happen with morphine more than anything else, more than fentanyl. It's usually almost always due to histamine release. It's usually short-lived and it responds very well to IV fluids. So just start hanging in a bag and it usually will correct itself within a few minutes. So elderly patients as a whole in pain management, right? They can be very challenging. They have multiple comorbidities. They also have a lot of other drugs on board. So you have the risk of drug-to-drug interactions. Opioid naive patients, so patients that have never taken opioids, if you give them a normal dose, they're usually more sensitive to it. They also have a longer duration of effect. So it's just something you got to think about. Most places will recommend just dosing your opioids in half for elderly patients, okay? So you might only want to use 25 mics of fentanyl instead of 100 mics of fentanyl for the 80-year-old with hip pain, right? Because you can always give another dose if the pain doesn't respond to that, but you probably don't want to hit them with 100 mics of fentanyl up front. And then NSAIDs, you really got to, Toradol basically is what we're talking about here. Toradol, you really got to watch out for elderly patients because they're more prone to renal injuries at baseline, right? They're going to, especially in the acute setting, they're not going to be taking as much PO. So they're already going to be set up for dehydration and acute kidney injury. So you really got to be thinking about that and say, yeah, I probably shouldn't give Toradol for those patients. And then addiction, we talked about at the beginning, right? So everybody's kind of worried about that and thinking about that when we're determining if we want to give pain medicines or not. So just some definitions of addiction, right, is the misuse of medication, detriment to the patient's well-being. That can happen just after one dose of heroin. Somebody can shoot up heroin and then they can start misusing it, but that's not really a dependence. Dependence usually takes a longer time, and that's actually a physiologic change in your body where your receptors are either upregulated or downregulated to where you actually require that drug to keep the same level of pain control, I guess you could say. Usually at least requires 4 to 6 weeks to develop. So again, we're going to be wanting to think about this in the patients. There may be some patients with some red flags, but at the end of the day, almost everybody will argue to just err on the side of caution, err on the side of, hey, I'm just going to give this person pain medicine because they could actually really be in pain. And again, you got to think about it. Somebody that's addicted can also be in pain for some other reason, right? They can have a traumatic event. So something to think about. And then, of course, anybody with renal dysfunction, you're going to avoid NSAIDs. Most of your analgesics are metabolized by the kidneys or the liver. Specifically in regards to opioids, I know not everybody has fentanyl, but fentanyl is preferred in renal failure just by the way it's eliminated. Okay, so I'm going to go over the anticipated new state protocol. So just you know, caveat, these actually haven't been released. We're not working under these protocols yet, but this is a what the new protocols could look like and are likely to look like. So I thought there's some good key points on this, right? So morphine or fentanyl should be used as primary analgesic, right? That's what I've already talked about for that severe pain. You're not going to want to lead with ketamine if you can. Fentanyl I didn't really talk about it, but fentanyl can be used intranasally if you have the means of doing that in the pre-hospital setting. It's really good because you don't have to stick a kid with an IV. And then talk about ketamine can be used for refractory pain, or if that's the only pain medicine you have, right? Toradol is an NSAID, so it can't be used in anybody with known renal history or somebody who's taken NSAIDs before. They're not really specific on this, but I think if it's the appropriate dose that they've taken and you're outside of that 4 to 6 window, it's still appropriate to go ahead and give like Toradol at that point. Again, mild pain, you're going to start with a Acetaminophen or Tylenol. You're going to want to know if they've taken any of that today. Again, if the pain, you know, this protocol kind of diverts you away from this if it's chest pain, right? Because chest pain is going to be a different pathway. You're not going to really want to use ketamine and things like that for chest pain. Think about giving Zofran. I wouldn't give it to every patient up front. I would probably have it, you know, quickly available in case they start having severe emesis. But think about it, especially if a patient tells you, hey, yeah, I've had this medicine before and I threw up with it. You know, you may want to go ahead and just give Zofran with it up front. And then this is your kind of clinical pathway you're going to use, right? So I'm sure a lot of you out there have looked at these a little bit, but it's kind of an algorithm approach now, how the new protocols are. And the little letters beside the boxes are your type of level of EMT and what you may or may not be in your scope of practice, right? So that's what those letters mean, right? So the first thing you're going to do, you're going to assess pain if it's 5 out of 10, right? So you don't have any contraindications to giving Tylenol. The pain is, you know, mild to moderate. It's not 2 or 3 out of 10. You're going to give a gram of acetaminophen. If it's mild, if it's less than 10, you're going to give Tylenol. That's what we talked about, right? Mild to moderate pain. If it's greater than 5 out of 10, severe pain, you're going to go down to your opiates or your Toradol. Okay, it gives your first dose down here. And I think I misspoke earlier. I said 15. It's actually 30 milligrams IV IM as your dose based off the state protocol that you're going to be giving. Again, when not to use it, renal patients, elderly. Morphine and fentanyl, and then if either you don't have morphine or fentanyl or Toradol, you can use ketamine, or if you've used a couple doses of morphine or fentanyl and you still have refractory pain, then you can think about moving on to ketamine. Okay. Most people, I would say, you're going to be pretty close to the hospital if you've already given 2 doses of an opioid. So, you know, I don't think ketamine is going to be used as much for pain after these new protocols come out. Again, the ketamine dose at 0.15 or 0.2 milligrams slow IV push, max of 25 milligrams down here on the bottom right, you can see for your ketamine. Again, not going to want to use it as in chest pain because that's just going to make the MI worse if they actually are having an MI. So I know that was quick, guys. So again, mild to moderate pain, Tylenol 1 gram. Severe pain, opioids, or in certain instances, you might actually jump to Toradol first if you're suspecting renal stone, kidney stones, or biliary colic, so some type of gallbladder issue. You're going to use the lowest appropriate dose initially, and then you're going to titrate to minimize adverse effects. You're going to remember to avoid Toradol in renal dysfunction patients, or in the elderly, or in any patient you suspect may be dehydrated and is going to have a kidney injury. Again, it's recommended for your elderly to reduce that lower initial dose of opioids. You might want to start out with 25 mics or 50 mics instead of 100 mics of fentanyl. Ketamine really shouldn't be used as a first line of pain control unless that's all you have, and it shouldn't be used in chest pain. I think I've kind of hit that enough. All right, cool. Any questions for me?
Awesome. Awesome. We do have a couple of questions coming online. I think you just answered them, but
Okay.
So the EMTs will, under the new protocols, be allowed to give acetaminophen.
I'll have to go back and look because you see the letters aren't up there beside it. So
Yeah. So I assume since there's no letters, it's all
Yeah,
certification?
I'm not sure, honestly. I can't remember when, during the Somatic meeting, what was talked about with acetaminophen. So I'm sure that would have to be clarified.
Do you remember off the top of your head what all is required for which types of agencies? Are these all, for example, is acetaminophen going to be required to be carried by all?
I can't remember acetaminophen. I believe Toradol is optional. So I believe Toradol is not going to be required. And by the year, or it was talked about by the year 2023, fentanyl or morphine is going to be required. So you're not going to be able to just carry ketamine only for pain control. So I do know that fentanyl or morphine is going to be required, but that's not until 2023. Again, I believe Toradol is optional, and then I can't remember about acetaminophen.
Okay. The other question that a couple of people have asked is all of these drugs are titratable. So do you have to start? Could you start at a lower dose than what's recommended?
Yes. Again, you got to think about your initial appropriate dose. Is why I said appropriate, right? So say morphine. You know, the actual initial dose that people recommend is 0.1 milligrams per kilogram. So you think about a regular adult, that's going to be pretty large dose. That's going to be 6 to 8 milligrams. So I think it's fine for those to give 4 up front. Your fentanyl is one that I would probably start a little lower if it's elderly. But again, it all depends on the patient in front of you and their comorbidities. If they've had opiates before, you know, it's going to be all depending on who's in front of you.
And then what do we do? Is there an amendment to the dose of fentanyl for kids if we're giving it intranasally? And I
think the 5 micrograms per kilogram IN up there for kids under fentanyl. So it is a little bit more than your normal IV dose. Instead of your 1 microgram per kilogram, you're going to be using 1.5 microgram per kilogram.
So obviously the fentanyl and morphine can be reversed with Narcan. Mm-hmm. So is there any danger? What does a Toradol overdose look like?
So really there's not any life-threatening thing that would happen initially, right? If you overdosed, and if you give this 15 or 30, you shouldn't have any issues. But theoretically, if you gave too much Toradol, you would just shut down their kidneys. And it would be a problem, you know, a week down the road, but it wouldn't be anything you would see immediately.
What's the onset of Toradol? How long could it take?
It'd probably be about an hour, 30 minutes to an hour. But again, it lasts longer. It's going to last 6 to 8 hours. So you might not see an effect by the time you get to the hospital, unfortunately. But it really works well for kidney stones. So if you can just convince the patient, hey, yeah, if you need this medicine, it should start working.
Good question.
Yeah.
Hey, Doc.
Yeah.
I've heard medics argue back and forth about pain management in potential head injury patients, you know, falls, MVCs, stuff like that. Mm-hmm. And the ones that are against it, specifically their rationale is that it makes the ED, it causes problems when you guys are assessing mental status and stuff like that. What do you think about that?
Yeah, so the question, if y'all didn't hear it, was giving opiates in trauma or TBI or head injury patients because you're concerned that it's going to decrease their mental status prior to arrival and they're not going to have a good assessment. So one thing I would say, if they're altered enough already, I probably wouldn't give pain medicine. If they're like a polytrauma and they're altered, they're probably not going to be worried about the pain as much. So I'd probably be a little hesitant there. But really, if you give morphine or fentanyl, it really should depress their mental status where they still can't answer questions and do everything appropriately that you should be able to assess their mental status, right? Most of the time in trauma patients that are altered, it's for a different reason. It's not because of the opiates you give them. And again, opiates might make you kind of slow to answer and things like that, but they shouldn't make you where you can't answer or your neurologic function is not intact, or you can't test it. So kind of a 2 answer there, right? If they're altered enough from a trauma, I'd probably not worry about pain control as much. But if they're alert, I wouldn't not give pain medicine and worrying about assessment. I wouldn't worry about it.
So what are your thoughts on giving opiates IM without vascular access?
So let's see. So I think it's fine. The big issue with IM is that it has a very irregular onset. So some people, they'll get onset within 30 minutes. Sometimes it'll take 2 hours for you to get onset of for IM. And also it might last longer. Some people, it doesn't last very long. And so it's just a very dirty way to give opiates. You know, I wouldn't worry as much about overdosing that way because it's going to have a slower onset. I think you just got to realize that you're not going to have a good effect with it, likely. A lot of people will advocate in the ER not to. I know a lot of people still do give it IM, but a lot of people advocate not to give it at all just because it's so erratic when you give it that way.
Very good. Any other questions? All right, thanks, Dr.
Yeah,
Dr.
no
Payne.
problem.
Great lecture. Glad to start delving into the new protocols a little bit and unpacking all that new information. This is going to be a process for everyone to recognize and learn and appropriately implement the changes. And a lot of progressive changes. We're moving things forward, but we have to do it the right way. So we're going to take a little bit of a break. We've got Dr. Rose will be coming up, giving us a lecture on burns in about 10 minutes or so.
I'm one of the third year residents. Did a few talks, so hopefully everybody is familiar with me or at least see me at UAB when you've dropped by a car. I'll let you know there's some gross pictures. Obviously it's burns, it can get pretty gnarly. The biggest things that we're going to cover is like types of burn, what are the big things that you need to recognize when you see somebody and kind of what you're going to do in the moments leading up to before you drop them off. There's 4 main types of burns, but we're not going to bother with radiation just because the chances of well, I don't know in today's political climate, but most of the time you're going to see chemical, electrical, and thermal. So those are the ones that we're really going to focus on. And this is also going to be a quick talk because it's essentially going to be following the exact same steps for like all the burns. So for chemical burns, you've got acids and bases, just depending on kind of what they were, exposed to. Acids tend to cause what we call a coagulative necrosis, and most of the time it's superficial. So we really want to focus on kind of washing it off. Bases get a little bit more difficult just because it can react with the fat in the skin and it causes liquefactive necrosis, and that damage can extend deeper than what an acid would actually do. So to sum it up, acids coagulate, which is mostly superficial, and then you've got bases which liquefy, and that tends to cause some deeper damage. So with chemical burns, it's always going to be, is the scene safe? Are you safe? And then when you come upon the patient, you're going to first check their airway, first check their breathing, circulation, obviously, CPR, if any of those are not working, or supportive care is needed. One of the biggest, most helpful things that you guys can do when you have these folks is to figure out what they were exposed to. Finding out the name, how much of it, and what route was it exposed. Is it aerosolized? Was it a liquid that was poured on? Where was the location? Is it hands, arms? Is there somewhere, did it soak clothing? And then how long were they exposed to it? Is it something that they immediately washed off? Is it somebody that was down and their arm was in and they couldn't, get out, and it was prolonged exposure? So all of these things are going to be important, and you can see different types of burns here. A quick thing that you can do if you're at some kind of facility, MSDS sheets, is to have somebody there. They should, where it is, or they should have a supervisor on scene that can grab you that, and even with the bottles, just having a quick photo just to take it, because most of the time with these chemical exposures that come in, we're going to end up calling poison control talks to see if they have any recommendations as far as anything that needs to be done further than what we usually would do. When you obviously, if somebody is drenched, going to remove the clothing. If it's a powder, what you're going to do is you're going to carefully brush it away and then start rinsing. And you really need to be thorough with the rinsing. So we're talking at least 30 minutes. Figure out a way to do it. If you need to set up suction, put a chucks under an arm and just keep it going, with an IV bag. You'll see here for people who have like splash burns, a lot of people cleaning their pool, you know, with pool chemicals, they'll come and they'll have a burn to the face or it'll get in the eye. I had a moonlight over at Blunt, and we had a guy who thought it was a great idea to boil an egg on a stove outside, and then he ran out of things to burn for the grill. So he started to put poison ivy to, you know, fuel the fire. And then he came in and obviously he had poison ivy all in his eyes. So, you know, in situations like that, these Morgan lenses, what you see on the bottom here, actually work fantastic. And I don't know if you guys have them on the unit, but you can do the same thing with a nasal cannula probe. If you can kind of MacGyver it to hook up to like a liter saline bag, and then you just kind of put the nasal prongs right on the nasal bridge and just let that fluid run, and it just kind of flushes both eyes, and it works pretty well. But it's going to be important to make sure that you irrigate. Amazing. And then obviously you want to get you kind of done your initial assessment and then get them on over to the closest facility. Electrical burns, so 10,000 annual visits. Usually there's like 3 main categories. One is small kids when they stick their finger in like weird places that it shouldn't. Teenage boys, I'm sure that all you guys can reflect on your childhood and remember all the things you did during your adolescence. That was probably not the smartest. And then adults that have occupational exposures, like the electricians, those that are working on like telecoms, all that. And then lightning strikes, which is very, very small amount, but you know, people die from it every year. I haven't seen it yet, but I'd like to see one. So as far as like electrical burns itself, understanding, you know, amps and voltages is kind of important. So current is measured in amps. What that essentially is when an electron moves, it will generate a current, and then voltage is the difference between the highest and the lowest point. There's different types. So high voltage, usually, you know, people will say 600 volts. For my boards, they tell us 1,000 volts. Most of the voltage that you'll get from like a home is going to be low. So, you know, you're not going to have these big cardiac arrhythmias or, you know, issues with burns. You know, there's concern for rhabdo. You won't really see that as much, but it's still something to be, you know, cognizant on. You're really going to see that in these high voltage burns. So those, especially, you know, the kids doing stupid stuff and those that are working, you know, with high voltage electrical lines. You got the different kinds of voltage, AC and DC. AC is more, you know, the one in the movies where they grab and they're like, and they can't let go. And then DC is the one that, you know, they fling back and all that dramatic stuff. Same thing, you know, is the scene safe? Are you safe to go in there? Making sure that you check their ABCs. So what you're going to do is, it's really important in these electrical folks to strip them down, because you want to see, you know, where the entry wound is. You can have an exit somewhere else. So you want to make sure that you're exposing everything. You can have, you know, superficial cutaneous burns. It can go down into the muscles and cause, you know, rhabdo. It can affect the electrical current of the heart. So, you know, getting an EKG is always a good idea. Again, you know, if it goes in one place, it can come out somewhere else. A lot of it, a good place to check is on the bottom of the feet, just because it enters the, you know, the path of least resistance, and then, you know, always check in just to see if there's anything where you usually wouldn't see it. So stripping them down. And then it can, these high voltage ones can cause a lot of electrical issues in range. So, you know, if you have the capability, if anybody, just get in quick to make sure that, you know, you need to at least, you know, let the folks at the hospital know. All right, so lightning strikes. So this is voltage in the millions, just as a kind of range. A standard taser is 50,000 volts. Some folks have this Lichtenberg mark, which I think is the coolest thing in the world. Like, I don't want to get hit by a lightning bolt to get it, but like that would be pretty cool to have that. Some things down the line, which you guys won't need to worry too much about, but it's kind of things that we think about. when somebody is struck by lightning is retinal detachment. So anybody with visual issues, that's just something that we need to be aware of. Cataracts can happen, but that's like later on down the line. And then people can have issues with tympanic membrane rupture as well. Almost 2/3 of cases can get that. So they can be complaining of, you know, hearing issues as well as visual change. Another thing to think about is a lot of these burns can be associated with trauma. So, you know, they were flung back, you know, something happened, you can have dislocations. So you should always, again, be thinking of these folks as if they're also trauma patients. And that goes with, okay, you've got this burn, you still need to get them undressed because you don't know what else you're missing. Did they land on something? You know, is something impaled somewhere? Is something dislocated? This is a shoulder dislocation right here. So always consider trauma as well in these high voltage burns. This is just kind of a little run through of a little algorithm, and it kind of walks you through it. So essentially what you're going to do is you're going to get to your electrical issue. You're going to check your ABCs, grab a quick EKG, determine what they were exposed to, and then figure out, okay, can we go to a local hospital? You know, is this something minor that, you know, Blunt or Sinclair can handle, or is this severe enough that we need to transfer them over to UAB? All right, so thermal burns, this is going to be obviously one of the bigger ones. So different categories, first, second, third, and fourth. So first degree is more like your superficial redness. One thing that's really important to note is that this does not count towards total body surface area. So a lot of people will be like 40% burns, and we're like, oh my gosh, anything usually above 20%. So there's certain burns that we do worry about. You know, circumferential is worrying. Anything in the airway is also worrying. 20% is usually our, okay, we've got to, you know, really take care of these folks. And we'll have, you know, again, folks that say, oh, it's about 40% will be like, this is bad, but a lot of it is first degree, so it doesn't count. So if you have somebody that has some superficial redness without any kind of blistering, then you don't need to count that. Second degree, so this is when you've got the blistering. You can have this kind of blanching of the skin. Usually what I do is if I see something like that, I'll press on it and I'll be like, are you feeling me here? If they say, no, I can't feel anything, that's the third degree. If they can still have sensation, then to me, that's second degree. So you'd count all of this as far as the actual total body surface area. And then third degree, pretty bad. This is when you've got char and it's down to the base. And obviously this is going to need reconstruction of some kind. And then fourth, so anytime you see charring, be concerned. Can you imagine intubating that? So everybody has seen this, but it's always good to go over. So this is your kind of diagram in order to determine how much total body surface area, and it's different between kids and adults because they have bigger heads. So the ratios as far as percentages is broken up a little bit different. I will always pull this out and just check. And honestly, if you ask 5 different providers, and I think these folks can vouch, if you ask 5 different providers what the TBSA is, you're going to get 5 different answers. And for me, the question really is it above 20% or not? Like, is it small enough? Is it like a 7 to 10%, or is this like a 28 to 32%? Because those are going to be managed very differently. Some people also use the rule of the palms, and it's important to just remember that it's the entire palm surface, and again, different between kids and adults. So just having a rough idea, even if you have to pull out that diagram again and just kind of figure it out, giving us a rough estimate, not including the first degree burns, it is really helpful. So again, you know, you get your call, making sure that, yeah, ABCs, all that kind of good stuff. Big things to be concerned about is with airway. Now, if you have somebody that has like a flash burn that's outside, that's going to be a little bit different to somebody that's stuck in a house fire, right? Because they're in a contained space. Their risk of inhalation injury is going to be a lot higher than someone who just like was setting fire and put some gas and it kind of flashed back. So those are the ones that you have to worry about. Looking in the mouth, just seeing if you see any kind of charring, if they're having any respiratory distress, if you hear any stridor. So I always think of stridor. If you have a squeaky door, it kind of sounds like that, that high-pitched sound. Those are all things that you need to be concerned about airway involvement. Reasons to intubate. So if somebody is obviously unresponsive, they're not protecting their airway, you've got to take care of it for them. And that's regardless of anyone, right? If you've got somebody who's unresponsive and they're not really doing as well, then I would expect that it would just be instinct for you guys to take that over anyway. Deep facial burns. So if you have severe char into the face, if you've got a lot of the black soot back in the airway, you know, you'll really want to be cautious. And then any respiratory compromise. So if you have that stridor, if you have someone that's breathing like, you know, 50, 60 times a minute, their O2 sat is like, you know, 82, 83%, and they're struggling, then we need to do something about it. Airways are going to be difficult, right? Because they're going to be swollen, they're going to be irritated, you're going to have a lot of secretions. If you can, and you have the ability, get an 8O ET tube. And the reason is because when we get them at UAB, we bronch them, and the bronch scope fits in an 8O. Anything smaller than that, it has a lot of difficulty. So usually we try to go with a slightly larger tube if possible, just to allow us to bronch and see what actual damage has been done to the airway. And then when you tube them, if you notice that, okay, initially they were doing okay as far as SATs, I was bagging them, and then they're having issues, just check your tube, because sometimes, you know, in these folks where the airway is so swollen, it can actually shift the tube itself. So you just have to make sure that it's like staying in place, like tape it down really good. If you need to advance it a little bit, re-listen to breath sounds, and, you know, you should be okay. Here's some pretty gnarly airways. Hopefully you don't ever have to see these tough ones up here. If you do see something like that, don't cowboy it, just grab a bougie. They are your friends, they're great. They're kind of like flimsy and annoying to use and to handle at first, just because, you know, the top flaps around. But once you get the handle of it, they can get in some really tight spots. And something I always carry with me as well is a pediatric bougie. So if you have the ability to grab one of those, I'd definitely grab them, because even in adults, when you've got something like this, where you're not seeing anything and you have like a pediatric bougie that you can pass through, because essentially it's just like a stylet, right? You're just using it to guide your tube over. So if you can get the bougie in there, then that's going to help you out a lot. And even if you are tubing, and I would just recommend, even on good airways, to just do a couple with the bougie, just so that you get familiar with it, because when you've got these tough situations, you really don't want that to be your first time, you know, being familiar with it. If you have the ability, go ahead and start some humidified oxygen via face mask if they're having issues with breathing, but they're not in any severe respiratory compromise. And make sure, again, you know, this goes back to exposing. If you've got, like, I don't know, some lady hit the club, she's wearing some skin tight pants, she got, you know, into a whatever she got into and she's burned, make sure you take anything that's restricting off them. And because, again, you know, if you've got that burn, it's going to start swelling almost immediately. You're going to get all that puffiness. And if she's already got, she or he already has restrictive clothes on, it's not going to help. So you want to cut all that down and kind of give it room to expand. Fluids are a big deal. In these severe burns, more than 20%, you really want to fluid resuscitate them well. It's something that UAB stays on top of. Everybody that's more than 20% will get a sheet, and every hour their urine output is matched with fluids. It's like a very meticulous process. Obviously, you're not going to know urine output, but if you've got a severe burn, grabbing access is huge. The Parkland Formula, this is something that we are, you know, taught on how much fluid to give. So it's 4 cc's times the total body surface area, obviously not included in first degree. And then you times that by the estimated weight in kilos. You're going to split that in half and give that essentially during, like, on the way to transport. The guidelines at UAB, this was pulled from our trauma book. What they usually say is 10 cc's an hour for total body surface area and 100 cc's for every 10 kilo after. So I gave 2 examples here. So 70 kilos at 40%. So that's going to be the 10 cc's times the total body surface area. So that's the 40%, which is 400 cc's an hour. The 100 kilos, since it's 20 over 80, you're just going to add an extra 200 cc's. This is a whole bunch of math that you don't need to care about. Just hang a bag and just start flowing it. Nobody is going to fault you for just like running a liter. So there's all these like Parkland formulas. There's all these like UAB guidelines of how they want things done. Just hang a liter, honestly. Like LR, you know, saline, whatever you had, preferred LR, but you know, it is what it is. Shortages and all that good jazz. So IV access, just start running some fluids, and you know, that will help a lot. Circumferential burns are a big deal just because they have the potential to cut off circulation and cause neurovascular damage. If we have anybody who's circumferential, you'll see the first thing that we do while the intern is like doing their, you know, breath sounds are equal, you'll see the upper level go over and they'll put a hand on the pulse just to make sure that a pulse is still there. If you don't have pulses, if the person starts to say that they don't feel anything in that hand and it's circumferential pretty severe, then that's when we start to think, okay, do we need to do escharotomies, which are essentially just kind of breaking up that burn and giving the space a place to expand. Actually, so, you know, in the ED, when we have severe burns come in, we don't do escharotomies that much. Like, it's not completely uncommon, but, you know, most of the time the burns aren't that bad. And we had a really severe burn come in, I think it was like 6-7 months ago. And it was, I think it was 85-90%, and the mortality at that point is like 0. So he got full body escharotomies, and Dr. Huang, who's the burn specialist, he was there. He let me do one side, and then the surgery resident did the other side, and it was the greatest day of my life. Isn't that like weird, things that we enjoy? But it was so satisfying because the compartments were like, you think of compartment syndrome, and when it's severe enough, you know, you'll touch on a wall and it'll feel like that. It's just like tough. And then we did the escharotomies, and then it immediately softened up and it just felt like a normal compartment. It's great. Plus I get to like zap and do things, you know, it smelled weird, but it's great. Here's an example of some escharotomies here. You've got the extremities. People do it differently. There's some other pictures here. Again, I told you these pictures are going to be gnarly. But you can have, you know, a compartment syndrome of like all types. You can have, you know, torso, extremities, and you really need to relieve that pressure in order to allow it to expand. This is not good. If you are at this point where, you know, there's a formula that you can calculate that can give you a percentage of like how likely you are to live. It's called Bowel formula. Nobody ever uses it. But burns, survival of this is not great. All right. So the big take homes is, if you got a chemical burn, grab the chemical data, get the MSDS, take a picture of the bottle. If it's an electrical burn, grab the EKG. Any kind of thermal burns, go ahead and intubate if there's any issues that you have with concern for airway. Any severe respiratory compromise, anybody comatose, get good access and start some fluids. And I think you will never go wrong if you just stick to these big points here. Make sure that you treat pain as well. That's a big thing as well. If somebody is in severe pain, burns hurt, right? You remember all those times that like you're cooking, you nicked your finger and you cried like a baby. It's like you're running it under the cold water. It freaking hurts. So just imagine that on like your entire arm. So be nice, give them fentanyl, morphine, whatever you want. Be generous. That's all I got. Yeah.
I got a question in regards to, you talk about humidified ice. For those patients that may have some irritation, but you know, we're taught in medic school, like patients like that can go downhill quick.
Yeah,
Start swelling, that kind of stuff.
yeah.
Could we get out ahead of that with the NSAID stuff and prevent some of that swelling, or is just the injury not gonna?
So,
I'm
yeah.
talking about two different kinds of inflammation.
So it's the same mechanism of inflammation, but the thing is that if you've got someone that's airway is burnt enough that it's going to swell and cause that severe airway distortion, no amount of ibuprofen is going to reverse that. And it's always a fine line of, you know, should I have intubated a while ago? And we have people from the community where it's like flash burns and they see the burns to the face, they freak out and they intubate immediately. It's always a tough call. I would say if you're starting to see desaturations, if you're hearing stridor, that's when I would start to consider, like early as well, you know, I'd consider taking the airway then, just to be on the safe side.
I think it's worth pointing out too, in the pre-hospital setting, thermal burns always look worse later. The best they're gonna look is right after they happen.
That's very true.
And it seems to be true for airway stuff as well. So I would suggest having a pretty high index of suspicion for airway burns. If the patient's having trouble speaking or has a hoarse voice, even if they're completely alert and oriented, it doesn't look that bad. That I've had several of those patients end up intubated.
And even still, like if somebody has hoarse voice, you know, and they're not having any tachypnea, or their O2 sats are fine, I think you're okay to hold then. But again, you know, if you have the hoarse voice and their respiratory rates in the 30s, 40s, or if they're sat in like 90, 89, then I'd be like, okay, now we need to do something about it. But it's always a tough call. It's like when we get trained on, you know, crikes, it's always like, when do you do it? You know, it's like, are you pulling the trigger too fast or are you waiting too long and your window has passed? It can get tricky.
So
Use your judgment.
we have a question about eye gels. I guess it could be applied to any supraglottic airway. Is there a role for eye gels in the airway burns?
Yeah, I think in a burn, if you have time to get an airway, get the airway. I think, like, when I say get the airway, I'm like talking about definitive airway as in intubate. If you either don't have the time or if you're close to the facility, you know, you can put an eye gel in. Because the thing is that even with these bad burns, if you're close to UAB and you just want to throw an eye gel in, either, you know, you don't have the time or, you know, you can't get the view, then it's okay. Because at UAB, we have more advanced stuff, like, you know, we have the video CMAC, we have anesthesia there, we have, you know, the fiber optic scopes that we can, we have a lot more tools in our arsenal. So I'd say in burns particularly, if you can get a definitive airway, get that airway over an eye gel. If you just don't have the time or if you just can't get it, just do the best you can.
So if they need airway control, we want to intubate, but if we can't, eye gel's better than nothing. Is that
Yeah.
good? Fair way to say it.
That's fair.
So another one of our guys just texted me, any capnography markers or benchmarks we should need to watch for in burn patients? In other words, does an airway burn affect qualitative capnography?
So that I don't know. I don't know the answer to that, if I'm being honest. Do you know the answer to that, T-Payne?
I don't think it would affect.
I would just use it the same way that I would in any other patient, if I'm being honest. Obviously, you know, if they're exhaling out enough, you know, where you're seeing a jump, you know, from 15 to 60, then I'd treat that the exact same way as I would in a ROSC. So.
Yeah, and then you also got to think about cyanide and carbon dioxide for your inhalation burns, because a lot of those coincide with that as well.
Mm-hmm.
But I don't think end-tidal should change. I can't think of any way it would change.
Other than just,
As long as you're still moving air, you should still have normal capnography.
Yeah, I mean, you want to look out for, you know, if you have them on nasal and you start seeing worsening respiratory effect and a rising end-tidal, right? That would mean they're underventilating, so that would be a concern. But that would be in any patient, not just for.
gotcha. So we got people asking, preventing hypothermia is important for thermal burns, and preventing infection is an important role for us. So how do we manage both?
So I wouldn't worry too much about the infection at that point. You know, the infection will usually happen later on down the line, and we'll take care of that. You know, when somebody comes in with bad burns, you know, they're going to the ICU, they're going to be having a close eye, antibiotics, all of that. So in the pre-hospital setting, I wouldn't worry too much about that. Definitely keeping them warm is a good idea though. So, you know, after you've done your assessment as far as stripping them down, making sure that there's no trauma, making sure that there's nothing, you know, as far as anything circumferential, removing jewelry, things like that, you know, taking off rings. Once all that is done, you know, making sure that you keep them covered, because you'll notice anytime you bring them to the burn bay, we always have it like, you know, a bajillion degrees in there. It feels like a furnace. But that's just because we don't want to, you know, increase acidosis with it being freezing cold. So we always want to keep them warm, keep them covered, put some blankets on them. Yeah.
One of the things that I worry about as a potential mass casualty incident is lightning strike during a mass gathering, like a high school football game or something like that. And I think one thing that's worth mentioning is that would be the one time we would treat the cardiac arrest patients first.
Yeah.
And I've always been fascinated by is it Lichtenberg?
Yeah, yeah, it's pretty
So
cool.
they're not really scars, are they?
I mean, so some people, I've seen pictures and like, again, you know, I've never seen a lightning strike. Apparently they fade over time. I don't know if there's anybody that's had them permanently. I wish that they did keep them permanently because they're cool, but yeah, I think they do tend to fade over time.
Yeah, I've actually read a couple of articles where people can have it, they can fade, and then during different physiological stress, they come back, which is really bizarre to me. Yeah, so lightning strike is actually something that is pretty common in this area.
I haven't seen it yet. There's no doubt it happens though.
I think it just usually happens where there aren't people.
Yeah.
But,
Yeah, my RV got hit by lightning a month after I bought it, so that's great.
very good. So there's no real external care that's that significant if we're talking about electrical burns, entrance and exit wounds.
I don't think that there's anything in the pre-hospital setting. I think it's just identifying, making sure that there's nothing else, and then, you know, getting that EKG is a good idea.
Something from my experience with a severe burn patient, you know, we obviously want to get anything that's still causing damage, we want to stop. So if they're closed or still smoldering or whatever, we got to get that off. But if they're wearing gloves with severe hand burns, that's a difficult thing in the pre-hospital setting because you really moving the gloves removes a lot of tissue.
Yeah, I'll just tell you though, if you bring them in with gloves on, we're taking them off. So whether you do it or we do it, they're coming off.
So no real trick there to reduce the damage.
I don't think so. Because I mean, most of these folks that come in, they get debrided. So when you've got these blisters, and I know we tell folks don't pop these blisters at home, but they get a good scrubbing when they come into UAB, and it's painful. Like, you know, we give them pain control to see if we can help it, but essentially we've got to take all that dead skin off, and then we put sterile dressings on it, like we've got Metalex, all kinds of different stuff, Cutisarin, and then that's when they go upstairs, and then Burn will see them and, you know, provide more in-depth wound care, figure out if they need grafting, all of that kind of stuff. But no, when they come in, after we've done our assessment, we usually just get a quick chest x-ray just to make sure there's nothing weird. But after that, they get a good scrub down. So we update their tetanus. If it's bad enough, we'll consider antibiotics. It's not usually a shotgun.
I know over the years, we've tried a bunch of different creams and topical applications for thermal burns, Silvadene, different jellies and stuff that have been tested in the pre-hospital setting. But currently, no creams, no lotions, no anything in the pre-hospital setting, right?
No, because we just clean it all off anyway. So the dressings that they have, you know, different medicated. Some have silver in it that they'll put on because obviously that has antibacterial component to it. But most of the time, no. You know, we're just getting a good assessment, making sure that they're neurovascularly intact in their extremities, making sure that their airway is good, and then just kind of taking it all down to the base. And then letting the burn team see them so they can figure out what the heck they want to do to fix it.
Sometimes with severely burned patients, like they have come out of a house fire, you'll see where lips and eyelids are missing or severely damaged. Anything in the pre-hospital setting to help eyesight restoration or preservation?
So What I would do is probably, if you get like a 4x4 and just rinse it in some saline and just kind of put that over the eyes. Obviously you want to be careful. You don't want to put any dry dressings on just because it's not going to be comfortable them taking it off. And then once they get to UAB, that's when we start like checking IPH, we'll call ophthalmology, and kind of do all the good jazz there. But I think just putting a wet dressing to cover the eyes just to help keep it moist wouldn't be a bad idea.
Anybody else have any questions for Dr. Rose? So, great lecture. We don't see burns that often, but it's always a bad call when we do.
Yeah, they get pretty gnarly.
So especially when it's something odd like a acid or base burn or a severe electrical burn. So we appreciate the update. Very good. Doesn't look like we covered every question online and on text. So everybody, thank you so much for participating. A couple of side notes, logistical notes. On the 4th Wednesday of this month, we'll be in Enterprise, Alabama. And that session will include a skills lab as well. So if you're in the area and you can attend with us, that would be great. We appreciate you coming. Then we're still doing some finalization for March, but it looks like we'll be here at Centerpoint on the 2nd Wednesday in March, and 4th Wednesday we'll be at Birmingham Fire at Girls and Training South. So we're looking forward to that as well. We still are trying to update our systems that we use to issue certificates. So there may be an hour or two delay in getting your certificates for today. If you have a certificate from a past class that you still have not received, you can still send it to, you can email me at wward@centerpointfire.com, and we'll get that taken care of for you. Sorry about those delays. We're trying to upgrade our system, so once we get all the bugs worked out, it should work even better, but it's a little painful right now. So today you won't get your certificate instantaneously, but it should be in an hour or two. Also today, if you fill out the attendance form, the password is Burns, B-U-R-N-S. If you didn't get it off the chat online, you can send an email to Alabama EMS, certificates at emschallenge.org. We changed our mechanism there, and you should get an automated reply with a link to that attendance form. Thanks, everybody, and we'll see you next time.